Good evening, ladies and gentlemen. For those who don't know, I'm Peter Joyce. I'm Dean of the University of Otago, Christchurch, and it's my pleasure to introduce this series of public lectures that we do at this time of year. Tonight is the fifth lecture we've done this year, and there are three more over the next 3 Wednesday evenings. Now, tonight it's my pleasure to introduce Dr. Tracy Melzer, who's one of our bright rising stars, and you may see his face in the newspaper on billboards, because Canterbury Medical Research Foundation have used him as sort of one of the bright researchers of the future. So Tracy initially started at the University of Canterbury and completed a physics degree and moved over to this campus in 2008. Completed a PhD with us under the supervision of Tim Anderson, who's one of our neurologists. And Tim has continued there with various research funding from Canterbury Medical Research Foundation, Neurological Foundation, and University of Otago. And it's a great pleasure to introduce Tracy to talk about brain imaging and Parkinson's disease. Tracy.
Great. Great, so thank you very much, Peter, and thank you very much for the invitation to present to you this evening. So, a very quick roadmap, so quick that there's no slide to tell you where we're going. First, I'd like to talk about brain imaging, in particular MRI. Secondly, let's talk about Parkinson's disease. And third, I'd like to mix the two and tell you what MR can tell us about Parkinson's disease. So let's get into it. So, MRI, for show of hands, if I were to say MRI, does anyone have any idea what I'm talking about? Yeah. Now my guess is probably a few of you who had an MRI. There are a number of you that have had an MRI scan for one reason or another. Well, at least there's a few of you out there who have heard the loud banging noises associated with MRI. But for those of you that aren't familiar with MRI, or magnetic resonance imaging, is an imaging technique which uses powerful magnets and radio frequency waves to create detailed images of the body. Now, one of the many benefits of MR is that it uses no ionizing radiation or no damaging radiation, which makes it safe and non-invasive. But also, by slightly adjusting a number of the different parameters on the scanner, we can create a whole host of different images. And these different images can tell us about different aspects of brain health or what's happening within the different organs. So it's a very powerful technique in that respect. Now, when I say powerful magnets, I really do mean strong magnets. So up there you see a junkyard magnet, and I'm pretty sure we can all agree that that's a very strong magnet, right? Just pick up cars, you can move them around the junkyard. Any ideas how this compares to the superconducting magnet, which is the heart of the MRI scanner? So I think it's more powerful or less powerful? It's kind of a loaded question. MR is definitely definitely stronger than this magnet, but it's about 3 to 4 times stronger than this magnet. So we really are talking about strong magnets. And also the radio frequency that I've mentioned, this is the same FM radio that you use to pick up in your car. Right? So we're talking about things that we can grasp, that we have an understanding of. Okay, now I promise that I won't spend the next hour bombarding you with equations and maths. But I would like to tell you just a little bit about how MR works. And the reason that I'd like to do that is because that's why I got involved in neuroimaging. So as Peter said, I come from a physics background. When I found out about the physics of MR, I was hooked. Right? It really is a fascinating technology. So, our MR magnet is tuned to hydrogen atoms. Okay? Now normally these hydrogen atoms, we have them, luckily, we have a lot of them. Because hydrogen is a big part of water, and there's lots of water in our body. So we have a lot of potential signal from the water in our body. Now normally these hydrogen atoms can be oriented in any which way. They're doing whatever they want to. Some are up and down and left and right. But when we put someone into a scanner, into an external magnetic field, what happens is these hydrogen atoms attempt to line up with that magnetic field. So you can kind of see that here in frame B. Right? So the hydrogen atoms line up with the external magnetic field. Right? Then what happens is we fire in a radio frequency pulse. Okay, now this radio frequency pulse basically knocks the hydrogen atoms out of alignment. It starts them spinning around. And then what we do is we just sit back and we wait, right? And what happens is different tissues will take different amounts of time to come back into alignment with the magnetic field, right? To come back into equilibrium. And when they do that, they fire off a little signal. And that's what we measure. So we collect these different signals from different parts of the brain, from different parts of the body. And the different signals correspond to different tissues. And using some fancy math and some processing, we can then create this nice three-dimensional image, like the one that you see along the bottom of the slide. So it's some clever work in creating these images, and I really do find it fascinating. So I mentioned that MRI uses no ionizing or damaging radiation, and this is an interesting point. It's an important point. So some of the other imaging techniques that you may be familiar with, like X-ray or CT, they all use X-rays to create images. Now, X-rays are very energetic, and they can cause some damage within the body. Right? Now, PET imaging, or positron emission tomography, which you see over to the right there, is another type of image which requires the injection of radioactive material into the body. So it uses radiation as well, and ionizing radiation. Now, it's undeniable that these imaging techniques have revolutionized medicine, right? But we do set limits on patient exposure to these techniques in order to avoid any potential damage that these techniques could cause. So if we're able to acquire images without this damaging radiation, such as in the case of MR, then all the better. So some will sell the principal benefit of MR being that it uses no damaging radiation. And this is, again, a valid point, but I don't think it's the most important thing about MR. I think the most exciting thing about MRI is the fact that, as I mentioned earlier, we can create many different types of images. Right? And you see just a few displayed here. So we can look at structure, at function, at blood flow, chemical concentrations, a lot of different processes in the brain or in the body that we can look at. So when you go for an X-ray, you have one choice, an X-ray. And it can be spectacular for some implementations or for some problems. But on the other hand, when you go for an MR scan, more than likely you will have a series of different types of MR to try and get a larger and more complete picture of what's happening in your body or in your brain. So what I'd like to do now is show you a few of these different types of MR, tell you what they measure and how we can use them in research. So we'll start off with structural MR. And here you see how I'll display the rest of the images for the talk, and that is as horizontal or axial slices. So this is as if you were looking down on the brain from above. So in the upper left-hand corner there, you see the side-on view of the brain, and there's a blue line. And that blue line indicates the level of the horizontal slice that we're looking at in the brain. So again, it's as if we're looking down on the brain from above. And on the bottom, you see three examples of structural MR. On the left, you see what we call a T1 weighted image. Now this is our high-resolution anatomical scan, which tells us about the amount of tissue, or the amount of particular tissue that we can see in the brain. And this is what we really use to look at structural changes in research. So if you start at the edge of that image and then move inwards, you can see a number of different tissue types. So if we start at the end, or out of the edge, what you'll see is I get my pointer up here. You can see here we have skull and scalp. Although if you look a little bit further out, you can see this is actually my brain from when I participated in an EEG study. So I have a cap on there with electrodes, and you can see how comfortable those electrodes were digging into my skin. Right? So you can see the skull and scalp here. If we move in a little bit further, we can start to see the brain. And what we see here are these beautiful folds, this slightly dark gray. We call that the gray matter because we're very creative, but we call it the gray matter. This is your cortex. This is where a lot of thinking and all processing happens in your brain. Now, if we move slightly deeper, let's see, down in here, this is what we call white matter. Right? And this is the tissue which connects different regions of the cortex, different gray matter regions. Right? So it's really important in communicating across different regions of the brain. And if we keep going down further, we see some more, let's see if I can get my pointer back, some more gray matter structures. We call these the basal ganglia. And then at the center of the brain, we have these fluid-filled cavities called ventricles. Now, these ventricles are filled with cerebral spinal fluid, which is a fluid that surrounds and bathes and protects the brain. Now, if we look at the further to the right here, these two images, these are what we call T2 weighted images. T1 and T2 are just magnetic properties that we can measure with MR. Now, these are more clinical images. On the far right there, you can see lots of white in the image. Right? Now, that white represents fluid. So you can imagine that this image is incredibly useful when we're looking for swelling, right, for extra fluid in the brain. Now, if we use a slight little trick when we're acquiring the image, we can get rid of that signal. And that's what you see in the middle. Right? That's called the T2 flare image, where we've gotten rid of the signal from fluid. So this one's quite interesting and quite useful when we specifically want to look at brain tissue. And this one's quite useful for looking at white matter damage, or usually about vascular origin, which I'll come back to later. So, again, we can't just have to look at single slices. Remember, we're looking at the entire brain, so we can actually form a series of slices, and that's what I have here. What I'll just start playing now is a series of slices which starts at the bottom of the brain and then moves sequentially up to the top of the brain. Now, the first time we'll play it through, I won't say anything. I'll just orient you slightly, telling you that up is where the nose is, down is the back of the head. And see if you can pick out the ears on either side of the brain. So, hopefully that'll work. Okay. Okay, so hopefully you picked up a few structures in there that look familiar to you. So we'll run through that again. So, starting at the bottom of the brain, now coming up, you can see the ears here on either side, the nose, we have the eyes, the sinuses here. Now we're into the brain, here are the basic ganglia and the ventricle, up into brain tissue, cortex, and then out the top of the brain there. And here we have another example. This one moves a bit quicker. Now, fluid's going to be bright, so particularly look at the eyes. They will stand out as being bright white. So you can see it coming through now and up through the top. Okay, so we're not even limited to just moving through slices of the brain, right? This is actually a three-dimensional image that we acquire, and we can do just that. What you see up here is a 3D representation of my brain. What I've done is I've got a slice on the side of my brain, so you can see in that beautiful, beautiful brain on the inside. Not that I'm biased. Right, so one of the things that you'll notice here is you do get really nice separation or differentiation between the gray matter and the white matter. So we can use that in our research to pick out what particular tissue we want to look at. Now, another thing to notice, I'll start this and it'll rotate around, we get really nice detail. So you can see my nose, I had my eyes closed during the scan. You can see my ear in quite nice detail. You can even see some of these vessels coming up from my neck to feed my brain. Right? And you can also see that I have quite a lumpy head, but that's okay. You can't win them all. So, one of, I think, the most striking applications of structural MR is loss of tissue, or what we call atrophy. Right? So on the left, you have, this is a 64-year-old male. He is in tip-top condition. His brain is looking spectacular. Right? Lots of nice folding. You can see the gray matter looks nice. The white matter is thick and juicy. It looks really nice. Over here on the right, we have a patient with Parkinson's disease, dementia. This is end stage. And so I think that the image speaks for itself, that you can see far less tissue here. It's a loss of tissue. So if we look here, we can see much larger ventricles. If you look around the edges of the brain, we see much more space. So we've actually lost a lot of that gray matter. And you can even see the loss of white matter. So if you look particularly over here, this is a white matter fiber called the corpus callosum. This is a big fiber that connects the left and right hemispheres of the brain. Over here, thick and juicy, nice and healthy. But if we look over here, you can see that that is thinned incredibly, right? Very, very thin over here. But it's not all dire or negative news. We can also use structural MR to actually show increases in gray matter. And so one of the questions that people have had for a long time is actually what happens in the brain when we learn new things, okay? And this is one of the seminal studies. This is an old study now, 2004, but this was asking just that question. What happens in the brain when we learn a new task? So they got a big group of university students together, and they scanned them all, okay? Then they divided them into two groups. One of the groups didn't do anything, they just scanned them again. But the other group they provided them with juggling instruction. Right? So they taught them how to juggle, they went through juggling until everyone could maintain the 3-ball cascade for over a minute. And then they scanned them again. And what they found in this group that learned how to juggle are in these areas of yellow, they had increased gray matter. Right? And some will jump to the conclusion and say, well, this is the juggling center of the brain. But that's not really the point of the study. The point of the study is saying that when you learn something new, you can form new connections, you can actually structurally change your brain. So this was a really exciting study, and from there it's exploded into, as you can imagine, functional changes, structural changes based on learning. We can now image those within a living person. Okay, so another type of image that we use in research is called this T2 flare, right? So this is the image that we use to identify white matter hyperintensities. And again, because we're creative, this is a hyper-intense signal in the white matter, so we call them white matter hyperintensities. But you'll see that you can identify those quite clearly here, and you have 3 examples. There's some happening here, and you can see some here. And so we can use some semi-automated algorithms to actually identify where those happen, and I've plotted those down in red. So this is a method that we can use to assess the vascular health of the brain in individuals. Now another type of MR is called diffusion MR. Now diffusion MR is uniquely sensitive to tissue microstructure. And the way that we do this is by making the MR signal sensitive to the diffusion of water, to the microscopic motion of water. Right? This microscopic motion of water, which is just because these water molecules have a little bit of energy, they're just vibrating around. And the microscopic motion of water is highly influenced by the underlying structural organization of the tissue. So we can acquire data, we fit a mathematical model called the tensor to this data, and from there we can acquire quantitative values of white matter health. Now, from the diffusion tensor imaging, we get 2 main measures. The first measure is called average diffusion. So you can see that on the left. And that quantifies how far the water diffuses out in the imaging time. So average diffusion, for example, if you're in healthy brain tissue, there are a number of barriers to diffusion. Right? You have organelles, you have cell membranes, but what happens is that water bumps into things, right? And it can't actually expand out. And so you have a small average diffusion. And you can see that by the gray in the brain tissue. But if you're in an area of cell damage or cell death, you have fewer barriers to diffusion. What happens is that water can actually expand out farther, and so you have larger average diffusion values. And you can see that in the ventricle here, this larger average diffusion. And the ventricle is just free floating water, essentially, and so that can diffuse out as far as it would like. Now, the other measure that we get is called fractional anisotropy. And this quantifies the directional variation. So what I mean by this is that FA, fractional anisotropy, can quantify, or can tell us whether water diffuses out beautifully and equally in all directions. So this is like the classic example of diffusion where you have a droplet of ink, and you place it in a cup of water, and it diffuses out beautifully and equally in all directions. But FA can also tell us whether, if water is constrained along a single direction. And this happens in the highly ordered, highly organized, myelinated white matter fibers, right? That white matter which I talked about earlier, which is the connection between different regions of the brain. And there, the water diffuses much more likely to diffuse along the tract than perpendicular to the tract. So we can use this information to actually trace out white matter fibers in the brain. And diffusion imaging also has so much information that we actually can't display this as a single grayscale image. And so we always have color to these images to indicate the direction that that white matter fiber is traveling. And that's what I have over here on the right. Here, red indicates fibers which are traveling in the right-left direction. Green indicates fibers traveling front to back. And blue indicates fibers moving up-down. So we can go one step further with diffusion, and we can actually trace out the individual white matter fibers. So here is a representation of a white matter fiber. Right? So we have tightly packed fibers here, and you can see the water is much more likely to diffuse along that tract than it is perpendicular. And so in its simplest implementation, what we can do is essentially connect the dots throughout the brain. So we start at one area in the brain, and we follow the direction of greatest diffusion onto the next area, onto the next, and so on. And in that way, we can actually trace out these beautiful white matter fibers, which you see here. So on the left, what you're seeing is a front-on view, so I'm looking at the brain this way, and you're seeing what we call cortical motor tracts. So these are the really important tracts that come up from your spinal cord, and then up to the top of your brain to the motor strip, and they send messages to control fingers and toes and all motor information. And you see those in blue there. Now on the right, you have, which is probably my favorite white matter pathway in the brain, which is called the cingulum bundle. Right? Now the cingulum bundle, you can see that here it runs front to back. It is incredibly important in transferring information from the front of your brain into the back of your brain, and vice versa. And so now with diffusion, what we can do is we can actually identify specific white matter tracts, go into those tracts and see, are they healthy, are they showing damage, what's the status? Now, the next type of MR that I'd like to talk about, which is particularly close to my heart, is blood flow imaging. Right? Now, this is a technique completely non-invasive and gives us a nice absolute measure of how much blood flow do we see passing through a particular area of the brain with every minute. And along the top, you'll see a raw image there. Now, you'll notice that actually doesn't look very nice relative to the structural images that I've just shown you. But we have a slight trade-off here. We don't have quite as much spatial resolution, but we do get nice functional information. Right? We know what's happening now in terms of blood flow to the brain. And what we tend to do to make up for that is we color code it and we stick it on top of the high resolution structural scan. So now you get nice structural information, and in color you see blood flow. Red is now showing increased blood flow, and blue is kind of lower blood flow. And lastly, we have functional MRI, which you may have heard of. Now, functional MRI is sensitive to the amount of oxygen in your blood, and we can use that to infer function. So the way that fMRI works is, let's say you perform some task, and that task may be looking at a flashing checkerboard. So when you see a flashing checkerboard, the area of your brain which is responsible for processing visual stimuli, which happens to be the back of your brain here, which you can see illustrated up on the screen, that increases its function. When it increases its function, it uses up all the oxygen in the area, and then to continue to function, we need more oxygenated blood. So we see this increase of oxygenated blood. That new oxygen in the area changes the magnetic signal. We can detect that change in magnetic signal and then work backwards to say, this is the area that must be working, must be functioning when we're looking at a flashing checkerboard. So up there you have an example of the flashing checkerboard. That's the part of the brain which is functioning there. And at the top, you have an example of what's happening when someone is tapping his or her fingers. Right? So you have one where he's tapping his right finger and one where he's tapping his left finger. And so you can see that this area and this area are responsible for moving fingers. Okay, and I can go on for ages and ages and ages, right? So hopefully that drives home my point that the great thing about MR is that we can measure lots. Structure, function, blood flow, metal deposition, vessel anatomy, chemical concentration. Right? So what have you. So, this is where my research comes in. So I use a number of these different techniques. And over at the New Zealand Brain Research Institute, we have a particular interest in Parkinson's disease. So my guess is that a number of you are probably familiar with Parkinson's disease. So you may have heard of it through these two individuals, through Muhammad Ali or Michael J. Fox. Or you may have a friend or family member that's affected by Parkinson's disease. Now, there are currently about 10,000 New Zealanders affected with Parkinson's disease, and the predictions are that this will increase fourfold by 2050. So this is becoming an ever-increasing importance in our society. So Parkinson's disease is a degenerative movement disorder which is characterized by resting tremor, slowness of movement, rigidity, and balance difficulties. And these can all contribute to a negative effect on quality of life. But in addition, a large portion of those with Parkinson's disease will develop some sort of cognitive impairment. And many will go on, many but not all, will go on to develop full-blown dementia. And as you can imagine, this adds even further hardship to the disease. So while these motor impairments dominate the early clinical picture, it's these later cognitive impairments which ultimately drive patients into institutionalized care. So over the past few years, there's been a real emphasis on trying to understand the process of cognitive impairment in Parkinson's disease, of characterizing those patients which are starting to show early signs of impairment, or what we call mild cognitive impairment. Now, patients with mild cognitive impairment are at an increased risk of developing dementia, and so the detection of these patients is particularly, it could be potentially extremely important, as these are the patients who are most likely to benefit from emergent therapies. Also, we will be able to select those patients and enter them into new trials aimed at either delaying or preventing cognitive impairment. But the reason I'm standing before you here today talking about this problem is because we have no method to do that. We can't identify those patients who are most at risk of developing dementia in the near future. We have no blood test, no genetic test, no cognitive test that will tell us this information. But we do think that neuroimaging, and particularly MRI, can provide us with a nice method to actually identify some markers which will be associated with cognition and help us identify those patients. And so that's where my work comes in. Right, so over the past few years, we've developed an MRI biomarker program. Right? And we have our overarching goal, which is to identify objective markers which can tell us about cognitive status in Parkinson's disease and actually track progression of the disease. So we started this back in late 2007 and started as a cross-section study. So we just wanted to see if we could characterize what's happening in Parkinson's disease from normal cognition all the way down to dementia. But we then realized we had the opportunity to follow these patients over time and see if we could track the progression of the disease. And so we now follow these individuals almost every 2 years. So saw them at 2 years, 4 years. We're about halfway through looking at our 6-year follow-up, and we've actually scanned a few individuals at 8 years after their first assessment. And I should probably mention that the way that we investigate these individuals is by looking at MRI at each time we see them and a cognitive assessment each time we see them. So the original study looked at 130 Parkinson's disease patients, and we used a cognitive assessment to characterize these individuals as having either normal cognition, mild cognitive impairment, or dementia. And we also looked at 50 healthy controls as well. And as I mentioned, at each time point now, we're looking at cognitive testing, clinical assessment, and MRI. So the first result that I would like to share with you is looking at what happened at baseline. What happened the first time we saw these individuals? Could we use MR to characterize what was happening in the brain? So first we'll look at these white matter lesions again. Remember, this is from the T2 FLAIR image, and we can identify where we're seeing these vascular white matter in this vascular white matter injury. So what you see here is what we'd expect to see in the group. So on the left, we have healthy individuals, and any areas of color that you see indicate the probability of identifying a white matter lesion in that area. So you can see that in healthy individuals, there is still a small chance of finding these white matter lesions, right? So anywhere from 5 to 10% chance of finding a lesion in healthy individuals. And that seems to be the case for those patients with Parkinson's disease and normal cognition as well. We don't really see any difference between those two. We do see differences once patients begin to develop cognitive impairments. And so you can see from the mild cognitive impairment group and the group with dementia 2 things. One, you see much more spatial extent, and you see the colors change. And those colors change indicate that now, in the dementia group, we have anywhere from 25 to 50% chance of randomly picking a patient with dementia and finding a white matter lesion in that particular area. So we do see an increase in white matter lesions with cognitive impairments in Parkinson's disease. Now, we also used a number of other imaging techniques, and thus the results are summarized here. So the rows indicate the type of MRI that I've used, and you can see the top row here is looking at structural changes, the middle row is looking at blood flow changes, and the bottom row is looking at the diffusion tensor changes. And the columns indicate the results in each group. So the first column shows us the group with Parkinson's disease and normal cognition. The middle row shows those with mild cognitive impairment, and the right shows us the group with dementia. So if we focus first on loss of tissue. So look at this first row. What you see is that any areas of blue and green here indicate significant loss of tissue. So if we look at the group with normal cognition and the group with mild cognitive impairment, what we see is they're looking pretty good. We can't find any loss of tissue, so they're looking relatively intact. However, when we look at the dementia group, that's not the case. We see some blue and some green here indicating significant loss of gray matter tissue. If we look at blood flow in the middle row, a different story, a different picture emerges. Once again, the group with normal cognition is hanging in there. They're doing pretty well. Their blood flow looks good. But this time, the group with mild cognitive impairment, we see here, and those with dementia are now showing widespread blue and green, indicating reduction of blood flow in many brain areas. And lastly, if we look at diffusion along the bottom, I've analyzed this in a slightly different way. I've focused my analysis down to the centers of the principal white matter tracts. So just the centers of those white matter tracts. And that's indicated here in green. And any areas of red that you see down in that lower row indicate white matter damage. And so if you look in the group with normal cognition, you're just starting to see a few areas of red indicating just a little bit of damage occurring in those white matter regions. But once again, once we move over to the group with mild cognitive impairment and then those with dementia in the bottom right, you can see it's actually quite difficult to find areas of green indicating that almost the entire white matter has become involved. So a few takeaway points from this. I think firstly, the finding here rests with the mild cognitive impairment group. And if you look at gray matter integrity, they look just like normal individuals. But if you look at blood flow, they're indistinguishable from those with dementia. So this structure blood flow mismatch or dissociation is a novel finding and could potentially provide us with a physiological measure to identify those individuals with mild cognitive impairment. But also, that mismatch can help us identify the mild cognitive impairment group as intermediate. Right? So if we look at a single imaging technique, they look indistinguishable from normals. But if we look at multiple imaging techniques, we can see that they actually fall intermediate to the group of normal cognition and those with dementia. And I think that there's a positive consequence here, and that is, it appears that these functional blood flow deficits occur earlier or prior to the extensive loss of tissue that we see associated with the progression to dementia. And so the idea is if we can target increasing blood flow in those mild cognitive impairment patients, potentially we can even delay or slow or even stop the conversion to dementia and loss of that tissue. And lastly, it also does appear that Parkinson's disease is associated with some initial white matter damage, irrespective of cognitive impairments. So we can see just very slight areas in those with normal cognition starting to show some white matter damage. But again, once we see mild cognitive impairment dementia kick in, we see that accelerating to include many areas in the brain. So it looks now as if we have a few measures which are starting to tell us something about the brain and its relation to cognitive impairment. Right? We can see differences across normal cognition, mild cognitive impairment, and dementia. But the real question is, can those actually tell us anything about the progression of the disease? Do they actually track the disease, or are they not particularly useful in following the disease? And so that's where we've now started to look at our longitudinal data, looking at what happens to these participants over time. And the way that I decided to look at that and present that here are looking at two particular measures. Now we're back to that white matter lesion. So what I've done here is I've gone through each individual and identified where those white matter lesions are, and I've come up with a single measure, which is the volume of those white matter lesions. Okay? And each individual at each time. And I've also taken our structural scan and I've segmented it into 3 different tissue types. Right? So that allows me to look at the gray matter in the brain, the white matter in the brain, and the fluid in the brain. And so what I do is I go back to the gray matter image here, and I basically again add that up. to come up with a single measure of the total amount of gray matter in the brain, the volume of the gray matter in the brain. And I have this measure in each individual at each time point. So let's first look at the white matter hyperintensities. So here's an example of an individual in our study. So this individual entered the study and he had normal cognition. And about 5% of his white matter was affected with lesions. So I think you can see those relatively clearly here. Now he came back at 2 years, again still had normal cognition, but now we're seeing about 7.5% of his white matter being affected. And he came back at 4 years and had developed dementia, and about 10% of his white matter is now affected. So I think that you can see, particularly if you look in this area, relative to his first scan, you can actually visually see that change. And I think you can also start to see some atrophy occurring here at the back of the brain relative to that first scan. So that's just a single individual. What does that look like across everyone? And here you have a relatively complicated graph, but I'm going to walk it through with you, and hopefully you'll understand it when I'm done. So what we have here is on the vertical axis, we have the volume of white matter lesions, right? The total amount of white matter lesions in the brain. On the horizontal axis, you have age, right? So it starts at about 50 up to about 85. Now, individual points represent single assessments, and lines connect multiple assessments within each individual, within a single individual. And lastly, the color indicates the cognitive status. So blue indicates a healthy individual, green indicates an individual with Parkinson's disease and normal cognition, orange indicates a participant with mild cognitive impairment, and red indicates a patient with dementia. So I think the thing that should be relatively obvious, or well, the easiest thing to see from this graph is the effective age. Right? So as we get older, we see more white matter lesions. And if I get rid of the Parkinson's disease patients there, hopefully this looks a little bit easier to see. So what you can see is that these young controls, they're just going along and they're doing well. Right? Nothing's happening. They're hanging out. There's no white matter lesions. When you get up to about 65, you start to see this increase, and then you see this increase in older age. Now this is a well-established phenomenon. We know that this exists, and this happens in healthy aging. But if we look at Parkinson's disease, hopefully you can convince yourself that it almost looks like the Parkinson's disease patients have been shifted down about 5 years. And so if we look at that statistically, what we can see is that we see more white matter lesions in patients with Parkinson's disease. We see more white matter lesions in patients with cognitive impairment. And the really exciting finding here is that the patients that later developed dementia showed increased levels of white matter lesions earlier, right? So now we're actually starting to find some measures, some MR-derived measures, which are predictive, or at least tell us something about cognitive impairment in Parkinson's disease and the progression of Parkinson's disease. So now if we look at gray matter volume, does this tell us the same thing as white matter lesions? Does it tell us something different? Is it useful? So here is gray matter volume in each individual. So now what you see along the vertical axis is the volume of gray matter in the brain. Again, age along the horizontal axis. And so now what you see is a different trend. Now you see this trend of loss of tissue over time. So if we get rid of the Parkinson's patients and logistic controls, you see this linear loss of gray matter over time. And again, this is well established. We know that this happens in healthy aging. But when I put the Parkinson's disease patients up there, it basically just looks a bit messy. But I can tell you from running the analysis that what we see there is, if you look at the Parkinson's disease group, they show accelerated loss of tissue. Right? They're losing tissue faster than healthy individuals. But if you consider cognition, that basically wipes out that Parkinson's disease effect. So what I mean by that is that Parkinson's disease patients with normal cognition don't decrease any faster than healthy individuals. It's the patients that are developing cognitive impairments which then begin to lose tissue faster than healthy individuals and those patients with normal cognition. Right, so now the question is, we're starting to see some MR measures which are telling us about the progression of disease. But are they useful? Do they tell us different things? Do they tell us the same things? And so what I did was I threw them all together to see if they could tell me anything about predicting cognitive impairment in each of these individuals. And what came out was that the most useful bit of information was the amount of gray matter volume in their brain, in their head. Sorry, the amount of gray matter volume in their head. Also, age plays a big part. And also, if we look at blood flow and white matter lesions to a lesser extent, they all tell us something about cognitive impairment in Parkinson's disease. So we really are now being able to extract some values that tell us about the progression of the disease. But I do need to throw in a caveat here, and that caveat is this is all at the group level. What I mean by that is this is all on average, right? So I look at an average individual with mild cognitive impairment. That person will accelerate, will lose brain tissue faster than a healthy individual. But if I have Joe over here who has a mild cognitive impairment, and I go and I look at Joe, I can't really say anything about Joe the individual. I can say something about mild cognitive impairment in general. And that's slightly frustrating to me, because I'd really like to be able to say something about an individual. And that's really where we need to go to make this clinically useful. We need to be able to use these measures to say something about the individual. And that's really where my research is going now. So, quick summary. We've been able to identify robust differences in the brain which are associated with cognitive impairments. So cognition in Parkinson's disease is associated with specific brain differences. And global measures can track the disease progression over time. And this is, again, encouraging because we can use some more sophisticated analyses, which is what I'm currently working on, to see if we can gather even more information, not just a single measure per person, but if we can look across regions in the brain and pull out the useful information. And that's what I'm working on now, and I think that actually will yield some much more interesting results. So if you could take away one thing from the presentation this evening, I would hope that you would take away MRI does tell us something about Parkinson's disease. I know that's quite a simple one, but I do think that's a powerful one. Okay, so I do have just a few more minutes here, and I'd like to tell you about some breaking news, some of our exciting research that we're just starting now. So I mentioned earlier positron emission tomography. So this is another type of imaging technology, which, as I said, requires the injection of radioactive material into the body. Now, if you can get your chemistry right, and there's some really good chemists out there, you can look at a number of different things with PET. And one of the things that we're interested in is looking at an abnormal protein called beta amyloid. So we know that beta amyloid is the hallmark of Alzheimer's disease. It misfolds, it goes abnormal, and it clogs up the brain of patients with Alzheimer's disease. So there's recent work showing now, if you look at the pathological literature, that about 50% of patients with Parkinson's disease and dementia have enough amyloid in their brains to have a secondary diagnosis of Alzheimer's disease. Right? So the question is this Parkinson's disease and Alzheimer's disease? Is it part of the same process? Is it a different process? And we don't know the answer to that question. But what we think is that the deposition or the abnormal folding of these proteins is probably bad. And if it happens, we're probably at an increased risk of developing dementia. Again, we don't know that. That's what we think is happening. So we've started a new project which is doing just that, looking at amyloid, this abnormal protein, looking at that deposition in patients with Parkinson's disease, and whether that increases their risk of developing dementia or not. So we've scanned 50 individuals now in this study, and they produce data that looks like this. Along the top there, you have an image of a healthy brain. Right? So this is a brain, this is a healthy amyloid scan. So if you look around the edges of the brain, the cortex, the gray matter, you don't see any red, you don't see any deposition of this abnormal protein, and that's good. If you look on the bottom, I think that you can convince yourself that is very different than the top. That's what we call a positive amyloid scan. And the red there indicates that we're seeing deposition of this misfolded protein in all areas of the brain. And so, as I mentioned, what we think is happening is that that's going to increase your risk of developing dementia. And we're really interested to see if that is the case in Parkinson's disease. So the message there is watch this space. So hopefully we'll have another tool to help us better understand cognitive impairment and development of dementia in Parkinson's disease. So Again, I need to finish by thanking all of our funding bodies. Imaging research is expensive, but I do think that it's valuable. Also, we work in a very collaborative environment, so I work with people from the University of Otago, the University of Canterbury, and the THB, and that all works very well. Lastly, I also need to thank the participants in our studies, because we'd be nowhere if we didn't have volunteers. So thank you very much, and I'd love to answer some questions.
Thank you, Tracy, for excellent talk. Time for questions, comments.
I may have missed something in your talk, but how did you identify those with Parkinson's disease that had normal cognitive function? So was there a genetic component to it?
So, two parts to that. One is how do we identify the patient with normal cognition. So when a patient comes in to see us, we have a cognitive or a neuropsychological battery. And that takes about 4 hours to complete, puzzles and tests and memory and all that, and based on that. Now, based on movement disorder criteria, which we've contributed to, there are set criteria for how well a person performed on those tests. Do they slot into mild cognitive impairment? Do they slot into dementia? If they don't slot into mild cognitive impairment or dementia, we consider them normal. So that's the answer to that. And the second is, was there a genetic component? We didn't start off looking at genetics, but we have now collected genetic material in most of our patients, and that's ongoing.
Yes.
I'm just curious to understand the clinical implications of whatever findings we found out, because it's obvious that there are clinical markers that separate individuals with MCI and dementia. So if we can pick up those markers in individuals who are showing MCI, are there alternate therapies or treatments available that can delay that MCI becoming into dementia? I think that would be the clinical implication of what we're discussing. So.
You're right. Absolutely. I completely agree. So I mean that's our ultimate goal, would be to identify markers which can actually then be used clinically. So the slightly long answer to that is that no, we don't have any treatments at the moment, any effective treatments for combating cognitive impairments in Parkinson's disease, or Alzheimer's disease for that matter. There are a number of things in the pipeline, and one of the problems is trying to assess those new therapies. Is it just symptomatic? Is this actually protecting the brain? And we don't really know. So one of the things that we think is great about imaging is that we would be able to assess those treatments. We would be able to tell if the brain continues to degrade or if the brain stops. Right? So we can actually assess whether new treatments are working. And that's one of the things that we're moving toward. The other thing is to use imaging to pick out individuals who we think are at the greatest risk, who would therefore probably be the ones most likely to benefit from the new therapies and get them into the new trials. So it's kind of twofold. It is kind of chicken and egg because we don't have any therapies that make a huge difference at the moment. So it's kind of chicken and egg, but we definitely need to do it.
There might be some updates now. About 10 years ago, we were using, where I was, we were using PET scans sometimes to see how much was an older person of primary severe depression or secondary to developing other problems. What's the story now?
Specifically with depression?
Yes.
In Parkinson's disease or depression in general?
Whether it was primary depression or whether it was secondary to developing other problems.
Right. I think that still remains a difficult question. It's hard to separate out whether, what comes first or what's a consequence of what. But as you bring up, it definitely is. It is an issue in Parkinson's disease. We know that depression exists. So, and it's slightly difficult to. I wonder if it's. Do we need to know if it's depression first or is it depression in Parkinson's? Fundamentally, we want to treat the depression, whether it comes through Parkinsonian or non-Parkinsonian. So, it remains a difficult question. And unfortunately, I don't have a great answer for you there. But we do know it's an issue, and we do continue to look at it and try to deal with it as best as possible.
It came up in terms of treatment for severe clinical depression, in terms of should they, if the medication hadn't worked, should they have ECT or not, but not if they're if it's really secondary to other developments.
Right. Well, I actually don't know enough to comment on that one, unfortunately, sorry.
Is there any difference in brain function or brain imaging between the people with frozen Parkinson's and the ones who are all over the place?
That's a good question. So, sometimes people like to talk about Parkinson's as tremor dominant or as posterior gait dominant, as in separating out the different motor components of Parkinson's. And when people have looked at the brain images in those individuals, they do see differences between those two, if you want to call them subtypes, of Parkinson's disease. What some people say are that the posterior gait type of Parkinson's are more likely to develop cognitive impairments than the tremor dominant. So whether we're seeing differences based on cognition or just differences based on the motor profile, we still don't know the answer to that. So there is work looking at that. And again, the picture muddies when you start to think about all the aspects of Parkinson's disease. It's not a simple disorder.
Thank you.
Yes?
Why is the increase, looking towards the future, of people with Parkinson's increasing at such a high rate?
Well, we don't actually think that so basically because we're living longer. So we know that Parkinson's is associated with older age. We're living longer as a society, and so as a consequence, we're going to see more Parkinson's. We don't actually think that the absolute incidence is increasing. We think that the incidence is staying constant. We're just seeing more people living longer. So a consequence of better lives, I suppose.
Yes?
Tracy,
No further questions?
hey. How close are we to actually seeing MRI as a potential diagnostic tool for Parkinson's? Because I suppose with any Parkinson's research, the difficulty is that some of the people on your study may not actually have Parkinson's because you don't have a clear diagnostic tool. And if we do have something, what do you think it will be? What would we see?
Yeah, so just a quick distinction. So what my research focuses on is when someone has Parkinson's, or we think that they have Parkinson's, what can imaging tell us about the cognitive progression? But I guess the question here is more of a diagnostic question. Can we use imaging to actually diagnose Parkinson's disease? There's some interesting work out now looking at specifically focusing on substantia nigra. So substantia nigra is one of the structures which was first hit in Parkinson's disease. And there's been some interesting work looking at diffusion MR showing perfect sensitivity and specificity. Again, that was a small study, so whether that's actually as good as it sounds, we don't know. Prime time in terms of diagnosing Parkinson's based on image, we're miles away. We're miles away from that. But following up on that, is it idiopathic Parkinson's, or is it a different? Is it multiple system atrophy or PSP or something? There is a fair amount of literature out there showing that you can see some differences, but it's nowhere near the sensitivity and specificity that we need to actually make informed clinical decisions. So we're just not there yet.
So the people on your study, when they pass away, will their brains go to the brain bank to confirm their diagnosis and then be able to unite that with your research?
So we have not done that to date, principally because we don't really have a brain bank here, but now as part of there's now a nationwide initiative called Brain Research New Zealand. It's a centre of research excellence, and it's based in Auckland and Dunedin, but we participate as well. They have the brain bank up in Auckland, and as part of our research, we may offer that to some interested individuals as an option, potentially in the future, but we haven't done that yet.
Yes.
There's a lot of interest currently in sport injuries, particularly concussions, in impact sports. Do any of these MRI techniques offer any possibility of earlier diagnosis of risk and potential for Parkinson's-related disorders resulting from head injuries, and thereby being ultimately able to allows athletes the potential of playing those over.
Right. Again, a very sensitive topic, very interesting topic, in my opinion. So, some of the work looking at diffusion, so mapping out those white matter fibers. Some of the concussive injuries can actually kind of shear, get some shear and kind of rub against those white matter fibers. So there's been a little bit of work looking at diffusion MR in concussion, in traumatic brain injury. But probably the most interesting, at least from my perspective now, is a positron emission tomography technique, a PET technique, which actually we're planning on starting as soon as we can get the tracer, which has to be produced in Melbourne. What this tracer will do will allow us to look at tau. Tau is another protein which we know is associated with Alzheimer's disease, but there's some new work showing that actually happens in concussion and repeated head injury, that we see the deposition of this misfolded tau protein. And that actually might be one of the most sensitive measures for concussion, for damage occurring post-concussion. And we think that actually might have happening in Parkinson's as well, but we don't know.
Will that allow earlier risk assessments and progression of concussions?
Will that allow for earlier? Well, it very well. I mean, if it plays out, and it does, the early research coming out of the football studies, the American football studies, using this tau PET, is looking pretty convincing that this could be a very early measure in the severity of brain injury post-concussion. So potentially, but we're not there yet. It's still pretty early days there, but that is actually much closer than a lot of these new techniques.
Maybe I can follow. You put up two famous people with Parkinson's. One of them being Muhammad Ali,
Yes.
probably secondary to the boxing.
Yeah.
Are there differences in the images for those who develop Parkinson's post-trauma as opposed to a more idiopathic Parkinson's disease?
Oh, yeah, that's. I don't know the answer to that. I haven't looked at the literature of, yeah, yeah, exactly. I don't know.
Mike?
That's what I was asking. How do they measure tau in those American football studies just mentioned? What do they measure?
So they measure. They use positron emission tomography, and they use a radioactive tracer, which is linked to a chemical which binds to tau. And so when it binds to tau, it then shoots off radiation. We detect the radiation and work backwards to find out where it came from, and so we can actually measure the amount of tau. So it's not an MR technique, it's a positron emission tomography technique. Yeah. Oh, very cool, very cool. And we actually have funding to start that at Parkinson's. So we're really looking forward to that. That could be very interesting.
Yes. Is it more a male-dominant disease than female?
Yep, that's correct. There's about two-thirds male and a third female.
So would that lend itself to the implications about sporting injuries because it's male?
I don't know if we have that data on hand. My guess would be probably not. Probably not a direct outcome of sporting. I mean, it could be, but the numbers on that mismatch between the males and the females seem to be pretty consistent across every country that I've seen data from. Maybe that is just a reflection of all males in all countries doing more head injury prone sports, but my hunch is that it's not. But I don't have any hard data to back that up.
Yes.
Is there any association between this deterioration in the brain and having strokes?
I mean, the short answer would be yes. I mean, the short answer is you don't want strokes for maintaining. So, when you have a stroke, you have a bit of damage to the brain. And that damage, whether it's restricted to a particular area or it increases to include a large area, that can lead to cell death, to brain tissue death. And when you see that death, you do inherently see some deterioration. So one of the things that I'm looking at now is what we call microbleeds. So very, very small stroke, very, very small, what we call silent strokes, and that you can't see a clinical presentation. And we're trying to see if we do see an association between those very small strokes and tissue degeneration or cognitive impairment. So my hunch would be, yes, we definitely do. My guess is there's probably literature out there to say that there is an association. And I don't have that on my fingertips in Parkinson's, but we are actually looking at it because we think that it probably does show an association.
Okay. Last question.
Is your research restricted to the access to a PET scan?
So my particular research, yes, is restricted to access to an MRI scanner or a PET scanner, because that's what I do imaging. But the group's interests are not restricted to imaging. So they do a lot of neuropsychological and cognitive assessment. They do a lot of eye movement assessment. They do clinical assessment. Tara sitting in front of you does a lot of physio interventions and movement assessment. So we span the range, or attempt to span the range of interesting things in Parkinson's disease, not restricted to imaging, but personally, basically restricted to imaging.
Perhaps the last comment, the Christchurch radiology group want to give a combined PET MRI all in one machine, and with luck, in the next 2 to 3 years, they will have one in Christchurch so that it can be used for studies such as this. So without more ado, thank Tracy very much for a very interesting talk and ask you to show your appreciation in the